AI is catching cancer years before your doctor can, and it's already in hospitals. Let's start with a number that should stop you cold. Pancreatic cancer kills more than 90% of the people who get it, not because it's some unstoppable force of nature, not because it's inherently untreatable in every case, but because by the time anyone finds it, by the time a patient notices something is wrong, by the time a doctor orders the right test, by the time a radiologist reads the scan, the cancer has almost always already spread to the point where surgery isn't possible and treatment options are severely limited. The cruel reality of pancreatic cancer is that it is often very treatable in its early stages, and it almost never gets caught in its early stages. That is what makes what happened in April 2026 so significant. Researchers at the Mayo Clinic published a study in a journal called Gut, one of the most respected gastroenterology journals in the world, describing an AI system that analyzed routine CT scan images and detected pancreatic cancer up to 3 years before a clinical diagnosis would have been made. Not in a lab, not in a simulation, in real patients whose scans existed in the medical record, who went on to receive a pancreatic cancer diagnosis years later, and whose scans the AI was able to go back and analyze to show that the early signs were there all along, invisible to human eyes, but visible to the algorithm. In a validation study, the system detected pancreatic cancer in nearly 3 out of 4 cases, approximately 16 months before clinical diagnosis, in some cases more than 2 years before. The detection rate was nearly double what specialist radiologists achieved reviewing the same scans without AI assistance. Let that land for a moment. Double the detection rate on the same images that human experts had already looked at and cleared. This isn't a criticism of radiologists. Radiologists are extraordinarily skilled professionals who do extraordinarily difficult work. The point is that AI can see things in imaging data that are genuinely invisible to the human visual system at early stages. Subtle statistical patterns across thousands of pixels that no human could be expected to notice, but that an algorithm trained on millions of scans has learned to recognize. And pancreatic cancer is just one example. Let's zoom out. In April and May of 2026, 2 landmark studies reshaped how the medical community thinks about AI-assisted cancer detection. The first came from a team at the Hong Kong University of Science and Technology and was published in Nature Cancer, one of the most prestigious medical journals in the world. They introduced a system called PRET, which stands for Plug-and-Play Retraining-Free Pathology Foundation Model. The name is a mouthful, but the capability is straightforward. PRET can recognize 18 distinct cancer types from just a handful of tissue slides, without needing any additional training for the specific hospital or patient population where it's deployed. You take it out of the box, point it at a slide, and it works. 18 cancer types, from a handful of slides, with high accuracy across the board. A separate analysis aggregating research published between 2024 and 2026 found that AI systems are detecting cancerous lesions an average of 40% earlier than human radiologists working alone, not in some narrow, cherry-picked application, on average, across multiple cancer types and imaging modalities. Now let's talk about what that 40% number actually means for a real person. The single most important factor in cancer survival is the stage at which it's caught. This is true across almost every cancer type. A stage 1 breast cancer diagnosis carries a 5-year survival rate of 99%. By stage 4, that number drops to around 28%. For lung cancer, the 5-year survival rate at stage 1 is around 60%. At stage 4, it's around 6%. Catching cancer earlier doesn't just improve the odds. In many cases, it is the difference between surviving and not surviving, between a treatment that works and a treatment that only delays the inevitable, between a patient who gets to watch their kids grow up and one who doesn't. So when we say AI is detecting cancer 40% earlier, we are not talking about a minor clinical improvement. We are talking about something that could meaningfully change whether people live or die. Let's talk about some of the specific applications that are already deployed in clinical settings, because this isn't all future tense. This is happening right now. In lung cancer screening, AI systems analyze CT scans to identify tiny nodules, small clusters of cells that may or may not develop into cancer. Human radiologists are very good at their jobs, but the volume of imaging that modern healthcare systems generate is staggering. A busy radiology department might review hundreds of scans in a single day. AI systems can analyze those same scans in seconds, flagging the cases that need immediate human attention and helping ensure that nothing critical gets missed in the sheer volume of work. A collaboration between Massachusetts General Hospital and MIT produced a system that achieved 94% accuracy in detecting lung nodules on CT scans. The comparison point is that human radiologists on the same task scored 65%. That is not a small gap. That is a transformative gap. In breast cancer screening, a South Korean study found that AI-based diagnosis achieved 90% sensitivity in detecting breast cancer with mass, compared to 78% for radiologists. In early breast cancer detection specifically, the AI achieved 91% accuracy versus 74% for the human experts. Again, those are not minor improvements. Those are the kinds of numbers that change clinical practice. In diabetic retinopathy, a leading cause of blindness in people with diabetes, AI screening systems have been cleared by the FDA for autonomous screening, meaning in certain clinical contexts, the AI can screen patients and provide results without a doctor reviewing every single image. This is significant because diabetic retinopathy is enormously common, the screening is simple, and the rate of people who never get screened, particularly in underserved communities, is high. An AI that can screen autonomously at scale is an AI that can prevent blindness in people who would otherwise never have been caught in time. In emergency medicine, AI triage systems can identify large vessel occlusions, the most severe type of stroke, from brain imaging, and immediately flag those cases as critical, pushing them to the top of the review queue. In stroke care, time is everything. Every minute of delayed treatment increases the amount of brain tissue that dies. An AI that ensures the most critical stroke cases are reviewed first, rather than sitting in a queue behind less urgent cases, saves brain tissue. And brain tissue that is saved is function that is preserved. Now let's talk about how these systems actually work in practice, because there's a common misconception worth addressing. AI diagnostic systems are not replacing radiologists and pathologists. That is not what is happening. What is happening is something called the dual reader workflow, and it is actually well established in radiology from before AI was involved. The basic idea is that two readers reviewing the same image catch more than one reader alone. AI functions as a second reader that is always available, never tired, never distracted, and has been trained on millions of cases. In practice, this typically looks like the following. A patient's imaging study comes in. The AI analyzes it and generates a report, flagging any areas of concern, prioritizing the cases that appear most urgent, and providing a preliminary read. The radiologist then reviews the images together with the AI's findings. The radiologist applies clinical context, judgment, experience, and everything the AI cannot provide. Knowledge of this specific patient's history, the reason for the scan, the clinical picture. The AI and the radiologist together produce a final interpretation. Neither the AI nor the radiologist alone is as good as the two working together. That is the point. And increasingly, that combination is becoming the standard of care in high-volume imaging centers around the world. Now let's talk about what all of this means for you as a regular person navigating the healthcare system. The first and most important thing to understand is that if you are overdue for any kind of cancer screening, a mammogram, a colonoscopy, a low-dose CT scan for lung cancer, if you're in a high-risk group, a PSA test, a skin check, the case for doing it has never been stronger. The tools being used to analyze those screenings are better than they have ever been. The window between early and treatable and late and difficult is being widened by these systems. But the system can only help you if you show up for the screening. The second thing to understand is that AI diagnostic tools are not equally available everywhere yet. Urban academic medical centers and large hospital systems have been faster to adopt these technologies than rural or underserved facilities. If you have access to a large hospital system, particularly one affiliated with a medical school or research institution, the likelihood that AI diagnostic tools are part of your care is higher. The third thing is that you are allowed to ask. If you receive imaging results, you are allowed to ask your doctor whether AI-assisted analysis was part of the read. You are allowed to ask what systems your facility uses. You are allowed to advocate for yourself in a healthcare system that is changing rapidly. Now let's talk about the opportunity side of this story, because if you're watching this video and you're thinking about what AI in medical diagnostics means for careers and investment, the picture is genuinely compelling. AI diagnostics companies are among the most actively funded in all of health technology. The sector attracted enormous investment through the first half of 2026, and companies operating in this space include publicly traded names like Tempus AI, Butterfly Network, and Arteries, as well as private companies like Page.ai and Viz.ai that are growing fast. On the career side, the emergence of AI in medical imaging is not eliminating radiology jobs. What it is doing is creating new adjacent roles. AI implementation specialists who work with hospital imaging departments to deploy and validate these systems. Medical AI product managers who serve as the bridge between the clinical world and the technology world. Quality assurance roles focused on monitoring AI system performance in real-world clinical settings. And the radiology profession itself is evolving. The radiologists who understand how to work with AI tools are becoming significantly more valuable than those who resist the technology. For people who want to work in this space without a medical degree, health informatics is the clearest entry point. Health informatics professionals manage the data infrastructure that makes AI clinical tools possible. They work at the intersection of healthcare, data management, and technology, and they are in very high demand right now. The bottom line on AI in cancer detection is this: we are at an inflection point. Not a future inflection point that is still years away. One that is happening right now, in hospitals that already exist, with tools that are already deployed. The gap between what AI can see in medical imaging and what the human eye alone can see is real, measurable, and growing. And the implications of that gap for survival rates, for early detection, for the entire economics of cancer treatment are profound. The disease that kills you is not always the disease that's untreatable. Sometimes it's the disease that wasn't caught in time, and AI is changing that equation in ways that will save lives, including possibly yours. If this video changed how you think about what's possible in medicine, subscribe and stick around. We're covering the full revolution happening in AI and healthcare over the next several weeks, and each video goes deeper into a part of the story you probably haven't heard yet.